Today we would discuss pathologies relating with the tricuspid valve, and they've been discussed in other chapters also. For example, we discussed Epstein anomaly in congenital heart echo category. Anyway, we just wanted to tell you that the right ventricle pressures when they rise, tricuspid valve is not accustomed to handle that kind of volume overload. Why? Now, in a normal LV, this is what we call as a coaptation distance. This is an extra kind of coaptation for the mitral valve, but there is hardly any extra coaptation. That means the tricuspid valve is just kind of coapting at the edge. So when the LV dilates, you still have some margin, but when the RV dilates, there is no margin because the valves are already coapting close to the edges, and the tricuspid regurgitation happens very quickly. So if there is an LV dilatation, there is a very quick tricuspid regurgitation as compared to when the mitral valve starts regurgitating. That's exactly what was initially described about the tricuspid valve by Dr. T.W. King, and he described the tricuspid valve functionality, and he tried to dilate right ventricle and showed a leaking of the tricuspid valve. And initially they did not give importance to this tricuspid valve, been ignored for quite some time, and they said only this is supposed to leak when the RV pressure increase is just a kind of a release phenomena for the RV pressure. So tricuspid regurgitation, tricuspid abnormalities had not been taken seriously. So I would just tell you about clinical aspects of the tricuspid valve abnormalities before I tell you how to analyze that. Now we know that there is what we had been calling a functional tricuspid regurgitation. You have a patient with a pulmonary artery hypertension, you get a functional regurgitation. You have atrial fibrillation, there is a regurgitation. There is a mitral valve involvement, and there is a PAH leading to tricuspid regurgitation that we commonly get in rheumatic heart disease, let's say mitral stenosis. We've been treating mitral stenosis and ignoring tricuspid regurgitation, thinking that once we operate on a mitral valve, we repair the valve, change the valve, whatever we do, and the tricuspid regurgitation should improve logically, because once the PA pressures fall, the tricuspid regurgitation should actually fall. That exactly did not happen. So now these are the number of cases which have been done on the mitral valve with the tricuspid valve involvement. Only 16% patients had a severe tricuspid regurgitation, while others had something like a moderate to mild tricuspid regurgitation, and their mitral valve surgery was done without touching the tricuspid valve. And it has been shown that tricuspid regurgitation persisted in over 60% of the patients who mitral valve was repaired or replaced. So that means most of the tricuspid regurgitations continued despite managing mitral valve. So interesting studies thereafter came which showed that in case you do a mitral valve surgery without a tricuspid valve repair, and if the patient had a mild TR or no TR, the outcome was reasonable. But in case you have a moderate TR or a severe TR, look at the mortality or survival rates with the moderate and severe TR. Even mild TR over a period of time showed a worse prognosis. And this we knew from 2004 and many studies prior to that. Let's say if we don't do a surgery, we just do a balloon mitral valvoplasty for a typical mitral stenosis, and what you see in case you have a tricuspid valve annulus, which is the ERO, that is tricuspid regurgitation, is severe versus mild, look at if you had not tackled tricuspid regurgitation, the survival was really bad, about 40% after 10 years. That's not a good thing. So I just want to emphasize that a tricuspid valve should be given its due. And when you make an analysis of a mitral stenosis, please spend good time to make an assessment of a tricuspid regurgitation. Mention that's mild, moderate, or severe, and all surgeons these days should be handling tricuspid regurgitation when they handle the mitral valve, because if they try to do tricuspid valve surgery later on, redo surgeries are really very tough. Again, the event-free rate from balloon mitral valvoplasty by severity of TR, even with the mild TR, the survival, and moderate and severe TR, these are the kind of event-free survival which was not very, very significant. So now do understand that functional TR is important, and if it persists and if there is severe TR, you've taken care of mitral valve. We have enough number of patients in our clinical practice where TR is severe and that led to the right heart failure and a lot of symptoms of fatigue, lung congestion. So now you understood that tricuspid regurgitation is functional all right, but it's not a thing to be ignored. So now the tricuspid anatomy is little different from the mitral valve anatomy, because the RA muscle also is a part of the tricuspid annulus. Same is the fibrous annulus, and then even the right muscle, a part of the right ventricular muscle is a part of the annulus. You have an annulus, tricuspid valve, and chordae or a papillary muscles like we have in the mitral valve. It's slightly different than the mitral valve. It is tri-leaflet, and that's why it's a tricuspid valve. There is a septal leaflet, there is an anterior leaflet, and there is a posterior leaflet. So this is how you anterior leaflet, septal leaflet, and posterior leaflet of the tricuspid valve. And to your notice, septal leaflet is the smallest, while the anterior is the largest leaflet. Posterior is somewhere mid, and posterior leaflet has usually associated with variations. And what are the variations here? Now, this has been a recent classification of a tricuspid valve. Normally, we expect the tricuspid valve, as the name suggests, being a tricuspid. There should be 3 leaflets, posterior, anterior, and a septal. Type 2 is that it's a bicuspid valve rather than a tricuspid. The anterior posterior are kind of fused, and this looks like a bicuspid, like a mitral valve. It's called type 2. Type 3 being that one of the leaflets is split, right? It is made into 2. In A, it is anterior, which is split. In B, it is posterior, which is split into 2. And in C, this is septal, which is split into 2. That means rather than having a 3 leaflet, you have a quadrileaflet tricuspid valve. Then you can have a pentacuspid tricuspid valve also, and that's called a type 4. What is the kind of frequency we find these variations of the tricuspid valve? That's the frequency. The commonest one being a type A, that accounts for about only 50%. So it's a tricuspid leaflet. Its name is tricuspid valve, but it's tri-leaflet only in 54% of the cases. In 32% you get type 3B, which is that the posterior leaflet is split into 2. There are 2 posterior leaflets. It's a quadrileaflet tricuspid valve. And that's again what we wanted to show the tricuspid valve. Our common understanding had been, let's see what leaflets do you see on a 4-chamber view. On the four-chamber view, the leaflet which is close to the septum is a septal leaflet. The other leaflet is anterior leaflet. Posterior is not visible on a four-chamber view. At least that's what we thought. Now on a parasternal short axis view at the aortic valve level, you see there is a septal leaflet, again an anterior leaflet and not posterior leaflet. And we knew and thought that posterior leaflet is only seen on a subcostal view. When you go to a subcostal view, you see the anterior leaflet and the posterior leaflet. Okay, so that is what our conventional teaching had been for a couple of years. But now we are realizing when we are taking a four-chamber view, I mean, we are not cutting the heart right in the middle like in arrow number 2. We may be little inferior, we may be little anterior, so we may not be cutting the valve. So all these cuts what you get by rotation of your probe, four-chamber view looks almost the same. It's very difficult for you to differentiate from one another. Roberto Lang and Libedano had done good work on a three-dimensional echo, and what they did, this is the bileaflet mitral valve, anterior leaflet, posterior leaflet. Here you have this septal leaflet, you have this anterior, and that's the posterior leaflet. If the four chamber is formed by a cut here, that's what the four chamber looks like. Understandably, you'll get a septal leaflet and anterior leaflet. Okay, but if the cut is little posterior, just close to the coronary sinus, then you look at the cut, you see the same kind of four chamber view, but if here in this is the posterior leaflet and this is septal leaflet. So that means on the four chamber view, depending upon your position of the probe, you can see both anterior and posterior leaflets apart from the septal. Same is true for a short axis view. In case you are anteriorly placed, then the cut is like this, and then you see the anterior leaflet and a septal leaflet. If cut is little inferior, you get a posterior and anterior this thing. How do you make a posterior and anterior cuts? Now once you do a cut in this position, let's say, then we would first let's talk about four chamber view. Okay, now the first four chamber view, A or B, is this, right? In this cut, what do you see? Or little, if you go little anterior, you see septal leaflet and anterior leaflet, the four chamber which I showed you. That's the septal leaflet, yellow one, and a green one is posterior leaflet. Okay, so now the blue is, now if you cut the section here, you would get septal and anterior leaflet, and if you are little posterior toward this asterisk sign, which is coronary sinus, you'll get anterior and posterior leaflets. Same is true for subcostal view. In case you see a coronary sinus here, if you are cutting close to the coronary sinus, you would get anterior leaflet and you would get not posterior but septal leaflet. Okay, so that is coronary sinus. So in case you get little the cross section is towards the right ventricle, your little moved away toward the right ventricle where the inferior vena cava would appear, then you would have this as a posterior. So remember, when you are scanning it's good idea to go to a 3D to find out which valve leaflet is it. So now, after describing the anatomy and the correlation with the echocardiography, I am going to tell you the causes of a tricuspid regurgitation. It could be involvement of the tricuspid valve, its chordae or something right on the right ventricle, or its pathology could be a secondary to the right ventricular dilatation or secondary to the annular dilatation. It may be because of right heart pathology or a left heart pathology affecting the right heart. So now how do we assess tricuspid regurgitation? I do understand most of us are still doing tricuspid regurgitation by what is jet depth and jet area. Jet area is a common way of jet divided by RA area. That's what we've been doing in a quick echo practice, and that more of a visual impression what we make is that is mild, moderate or severe. But there are other methods which are more important to quantify the tricuspid regurgitation. As I told you in beginning of my talk, the quantification of the tricuspid regurgitation is important to tell the surgeon or an intervention cardiologist that when he is taking care of a mitral valve, the tricuspid valve also needs to be looked into. So we would start little from the hepatic veins where we can make an assessment of a tricuspid regurgitation. It's exactly the same what we do a pulmonary venous flow in a patient with a mitral regurgitation. In a normal wave form, what you get is this is A wave atrial contraction, small S wave between the Q and a T wave, small ventricular wave, and then you get a main diastolic flow. And in the beginning of a tricuspid regurgitation, when it's moderate, what you get is there is a flow reversal in systole, ventricular systole, and this is in the V. D becomes little smaller, but as the regurgitation is more, there is an S wave which is also inverted, and a V wave also is inverted like this. Only diastolic flow you see. So this is severe tricuspid regurgitation. You get an A wave and an S wave which are kind of combined, but you get only the D wave which is down, and this indicates a severe tricuspid regurgitation. Jet area method is very good. Please keep the Nyquist limit not more than 40. If the Nyquist limit is more than 40, then you would not be able to get the good jet area. It would become small. The best way is to do an apical 4-chamber view or an RV modified view. And if the jet is eccentric like mitral regurgitation, it could underestimate, but fortunately tricuspid jets are usually central and they are not eccentric. So it depends upon the pressure in the right ventricle. If the pressure in the right ventricle is low, and in low pressure TRs, you would get a smaller area of tricuspid regurgitation, underestimating severity of. So when we planimeter the area, we call it a severe tricuspid regurgitation when the area is more than 10 centimeters square. You just planimeter, see what is the area. If the area of the tricuspid valve regurgitation is more than 10, it's called a severe TR. Okay. So then there are methods of calculating effective orifice area, regurgitation volume of the TR. They are time consuming and they are not very accurate either. So in both situations, we should have to have some shortcut, and I'm suggesting you one shortcut here. Now, if the PISA, now what you do is that you get the Nyquist limit to 40. Okay, the baseline, normally you do in a baseline shift, you get it to 40. So once you get it to 40, then you calculate the radius, the regurgitation. Now this is the area where the elacing is happening, and if this radius, PISA radius, is more than 9, this indicates severe TR. You don't have to go into too many calculations. And if the PISA radius is less than 0.5 or a 5 millimeter, then it actually indicates mild TR. So then is the vena contracta, like we do it in AR and MR. Vena contracta is the narrowest portion of the jet, and this is the broad portion, narrow, and again it widens. And severe, once you have a vena contracta of 7 millimeter, mild if the vena contracta is less than 3 centimeter or less than 3 millimeter. So that's how, but we do understand vena contracta is not linear. It may be curvilinear, and many times we can take an area of vena contracta rather than taking a diameter. So these are various parameters. You can halt on this slide, you can take a pic of the slide and use these methods for assessment of a tricuspid regurgitation. So then let us look at, when we talk about a tricuspid, you have a patient with a rheumatic mitral stenosis and you want to know if there is a tricuspid regurgitation. We are looking for two things: severity of a tricuspid regurgitation and the size of a tricuspid annulus. Two things. So now based on that, in case the TR severity is mild, annulus is normal, less than 40 or a 4 centimeter, the coaptation is normal, we continue with the medical therapy rather than doing a surgery on the right sided valve also while doing a mitral surgery. Stage 2, when it's mild to moderate, the diameter is more than 40 millimeter or 4 centimeter and the coaptation is just on the edge. So this is the stage where people recommend that tricuspid annuloplasty should be done in the same sitting when you are doing a mitral valve surgery. Now stage 3, when there is a TR is severe, when the annulus is dilated, there is non-coapting tricuspid leaflet. We've seen it a number of times, and that is where you actually do tricuspid annuloplasty and maybe an augmentation of the leaflets. So both tricuspid annulus as well as the mitral annulus should be looked into. So now there has been quite a variation in a 2D assessment of the tricuspid annulus, which actually what the surgeons find. Surgeons find the area to be larger than what we get, and normally when the area in an adult is 28 plus minus 5, but intra-op the tricuspid valve area is larger. Once we do a three-dimensional echo, try to get an en-face view of the tricuspid valve, reduce the gain so that you only see the annulus, and once you do the annulus planimetry, the area where here you calculate correlates wonderfully well with operative findings. So what are the indications of a tricuspid valve repair? I told you class 1, no doubt, severe tricuspid regurgitation, you must handle that. Class 2 indication, you should be doing it, moderate TR with annulus which is dilated. Okay, and class B, you can consider tricuspid valve repair when there is a moderate TR but tricuspid annulus is normal and the patient is undergoing mitral valve surgery. It all depends on the age of the patient. If the patient is younger, maybe we would consider to do tricuspid valve repair also, even in moderate TR and the annulus being normal. Another reason for tricuspid entrapment causing a tricuspid regurgitation is that if you put a lead, because we put a pacing lead which is kind of a blind procedure and it can impinge on, normally we are happy in case it's stuck with the commissure, but many times it's not with the commissure. It holds the one of the leaflet septal or posterior. When it holds one of the leaflet for coaptation because of the lead, it causes tricuspid regurgitation. I show you one or two just cases. One of the case is the mitral stenosis, and very rare to find a severe tricuspid stenosis with the mitral stenosis. Look at the PISA, and this is Now I'm showing you tricuspid valve annular dilatation. Look at the annular dilatation here, and now this is the diameter is more, and you see the non-coopting tricuspid leaflet. Understandably, we expected severe tricuspid regurgitation. Yes, we have torrential tricuspid regurgitation. Mind you, there are new classification of tricuspid regurgitation, which at least I don't use it as of now, but internationally there is a bit of a confusion. Many people say there is a severe tricuspid regurgitation, very severe tricuspid regurgitation, and torrential tricuspid regurgitation, or a to and fro movement tricuspid regurgitation. So I've graded severity into 3. Now there is a patient with an Epstein anomaly as shown you there, and this is right atrium. Now this is an atrialized ventricle. This is large anterior leaflet. This is septal leaflet which is tethered to the septum, and this portion behaves like an atrium. Right, this is another patient where this is the septal leaflet, this is the anterior leaflet, and this is the atrialized septum, and that's an Epstein anomaly. Another anomaly which I wanted to show you is unguarded tricuspid orifice, where the tricuspid valve is either absent or rudimentary, and this is one patient where tricuspid valve is absent, and this kind of masses are known. You don't see any septal leaflet, and you see this kind of tags. This is a patient with an unguarded tricuspid orifice. My first patient of unguarded tricuspid orifice was this, where you don't see a septal leaflet at all. Tricuspid leaflet of the anterior leaflet is kind of rudimentary. So are the papillary muscle, and you have a huge dilatation of the right atrium and a right ventricle, and you have a to and fro movement, what we call as a torrential tricuspid regurgitation. This is low pressure tricuspid regurgitation. In this patient, this was a rare anomaly. We had only one case has been reported in literature. That is, you have an unguarded tricuspid orifice and you have an absent pulmonary valve, and there is a continuous kind of flow in the pulmonary valve. That's something rare which I thought I'll share with you. So we've done with this lecture now on a tricuspid valve abnormalities, and I must tell you that you should do a 3D also in the tricuspid, so that you know which leaflet is involved, and you can see the cooptation very well. You can see the annulus very well, and accuracy of annulus and cooptation is far better on 3D than on 2D, and we know that 3D is far superior. And keep it in mind that tricuspid regurgitation is important for health and mortality, morbidity, and needs to be handled as aggressively as we handled mitral regurgitation.